Thank you so much, Dr. Himali, for your generous and lengthy bio. So I will put this. Can you all see my presentation now?
Yes, it's visible.
Okay, right. Perfect. So let's start the session. Today we are planning to talk or rather discuss on healthcare financing and rational decision making. So this topic, I think, is very, very crucial for all of us, especially from the healthcare sector, because all of you know that now we are facing, or we are in a crisis, you know. So whatever decision we make, or whatever decisions we have to make, or whatever decisions or evidence that we supply for decision makers to implement these decisions would affect everyone, especially the patients as well as the country's economy. So I think it's really this topic is really timely, and let's see if we can understand concepts of healthcare financing also, and also some concepts on how to make a rational decision making. Okay? Right. So today's lecture, we would be looking at the healthcare financing in Sri Lanka and what is risk pooling and the financial flow through the system, and then why do governments intervene, right? Why do governments intervene in healthcare provision? Because ours is a very unique situation where we provide universally free of healthcare, right? So we can walk into any institutions and quote unquote it's free of charge, right? Quote unquote. And then we will talk very briefly talk about a few policy tools that we use for decision making, or rather we have to use. Not that we don't use anything, but well, there are areas that we can improve. Okay, so this is a little bit of Sri Lanka. So we all know we call ourselves the Pearl of Indian Ocean, and it's a tiny country below India, right? So country demographics, we have around 22 million people living in 65,614 square kilometers. We have 9 provinces, 26 districts, and free health and free education. Okay, so why is it free of charge when the world is doing something else? Because in Sri Lanka, we think free health, free education is an investment. So because it's an investment, we think it has a big return on investment, right? So if people are educated and healthy, they contribute in the economic activities. Okay, so that's a big assumption that we have made. We have a network of hospitals. We have PMCUs up until tertiary cares to specialized institutions, and on average, we say 3.9 kilometers, or it might be 3.2 kilometers now. On average, the distance to any healthcare institution in Sri Lanka would be around 3.9 to 2 kilometers, right? So despite everything, our health statistics say on average our life expectancy is around 75 years, which is good compared to some indicators from the developed world, right? Maternal mortality rate, for 100,000 live births, our maternal mortality is 33, which is again a good indicator compared to the rest of the world. Especially, we have to keep in mind our resource allocation, no, our finances, the financial allocation. So considering that, what we have gained is good. Infant mortality rate, for 1,000 live births, it would be around 8, right? And vaccination coverage, we have an amazing vaccination coverage. We should give the credit to the moms also, our mothers, with their health literacy. The vaccination coverage is also pretty good. The problem is NCD burden, right? So it is slowly emerging. We have to, it's an emerging problem. We have to yet decide on the indicators and talk about it, right? So our purpose today is to talk about healthcare finances. Look at the figures. So it is the total health expenditure, THE stands for total health expenditure of the government gross domestic production. It's only 3.9, right? So in other countries, if you see, today I saw in USA, in the US, it's around 11. Okay, so let's forget about US, but even in Bangladesh, Afghanistan, or India, it's slightly higher than what it is, what we are spending, 3.9 gross domestic production of the national gross domestic production. What is allocated to the health is around 3.9, right? So because of that, let's see, the government health expenditure is around 1.7. So of the total health expenditure, the government only spends nearly half of it, 1.7. So where is the rest coming from? It is coming from the private health expenditure, right? So the private health expenditure consists of out-of-pocket expenditure and as well as private or volunteer health insurance. Okay, I hope you understand that bit. Now see, our out-of-pocket expenditure is 53%. According to WHO, anything beyond 30% is not so good. Out of pocket expenditure, meaning somebody has to pay out of pocket, right? Out of pocket for their health. An out of pocket expenditure would have the direct and the indirect component. Direct component will consist of the drugs, the investigations. Indirect component would consist of transport costs, food that they have to buy, okay, things like that. And also, so out-of-pocket expenditure. So when you look at health expenditure, there is another indicator that we calculate, which is catastrophic health expenditure. Okay, so the catastrophic health expenditure is think your monthly income, and then from that monthly income, what you spend for health, right? If that is the proportion. Okay, so if that goes beyond 10%, the cutoffs for catastrophic health expenditure is at 10%, 15%, and 25%. So in Sri Lanka, 1.1% population has a health expenditure which goes beyond 25%. So 1/4 of their income is for health for some reason. Okay. So what would happen? What would happen? That drives people into poverty. So therefore, WHO is now thinking of a new indicator, which is the poverty line, health poverty line, right? So what proportion is going into poverty because they have to spend for health? When people have to spend for health, and that is a reason for them being poor, that is not a good state to be in. Okay, right. Now, so the same thing I have been talking to you in a graph. Look at the graph. In red color is the out-of-pocket expenditure. What you have to privately spend, right? Nobody is looking after you for this expenditure. Out-of-pocket is what you have to spend. Voluntary health is your private insurance, and social health schemes is what we have, like Agrahara, Suraksha. You and I are covered, no? So we have. So look at the social health insurance. Can we see it even? Okay, so can we see it even? Very difficult, no? Can't even see. So that amount. But look at the blue chunk. Blue chunk is the government expenditure, the total health, the public health expenditure. I told you nearly 50% is from the government, nearly 50% is from the private health insurance. So not private health is insurance, it's private expenditure. So look at private expenditure. It consists of out-of-pocket expenditure and the voluntary health insurance. Now, voluntary health insurance is that yellow bit, right? So what we can get is how we can interpret it is our out-of-pocket expenditure is, it contributes a lot to our health expenses. So, and what government contributes has been more or less 50% or even less than 50%. Okay, or even less than 50%, because if out-of-pocket expenditure is more than 50%, that means government is spending less than that. So that is what in key statistics. See, for 2019, it says 45% 6. Government health expenditure is 47.2, around that bit, right? Okay, so we see that there is a problem. Objectives of any health system is to improve the health status of the population. Okay, so we want our people to be healthy. And then we also want everybody to equally have the healthcare, the health system, the healthcare provision. They should equally be able to access the healthcare. Okay, access in the sense not just walking into a health system, access in the sense it is access quality healthcare, access a health profession, and access to a health system, a health institution. So access in the sense all three or more components achieved, right? But you also have to keep in mind, while obtaining health, people not be thrown into poverty. Like I mentioned, the catastrophic health expenses, people should never be thrown into poverty because they have to take health, right? So the third one, right? The fourth one is so the health system needs to be efficient. Let's see what efficiency is in a bit, but a health system should be efficient. Okay, 3.6, 3.7, let's say 3.7 GDP, that is our allocation. But with that allocation also, the health system need to be very efficient in the manner in which they are handling it. Think of your household situation. So whatever the income that you're getting, if you are efficient, you will be able to manage the income and the expenditure, no? So you will be able to manage it within that household if you're efficient. But if you're inefficient, if you are just lavishly spending on everything and you don't know what the income is and you don't care what the expenditure is going to be, so that way you can go into bankruptcy. So similar thing that we have, the thing has happened to our country also, right? And then the health system would want to assure quality healthcare, not just any healthcare, so right, but it has to be quality so that we satisfy the patient. Now think about our health system, right? So we need to improve. There are gaps. Not that we are doing very, very bad. No, our health system, our indicators are good, and it is free of charge. How I see it is, there are efficiency improvements, definite efficiency improvements that can happen, and there we need to also keep in mind that we need to improve quality for the patient. Okay, right. And the good news is it's not just in Sri Lanka. All over the place, all his health systems are under pressure. Why are they under pressure? Because budgets are finite. Nowhere in the world they have infinite budgets, right? Nowhere in the world. Budgets are finite, meaning limited resources. But the disease burdens are changing, right? The disease patterns are changing. People are aging, communicable diseases as well as non-communicable diseases. So there are problems within the system. And plus, on the other hand, the people, our consumers, right? Our consumers are the patients. they are expecting good quality drugs, equipment, better quality treatment, and less amount of days in the hospital, and less waiting time. So their expectations are also very big. And on the other hand, pharmaceuticals, the companies, they are growing. People are doing research. They are putting out a lot of technologies, and there are a variety of drugs and equipment that we have to choose from, right? So all over the world, the health system, these things are faced by one health system, no? It would be the Ministry of Health or the Indigenous Medicine, the ministry. They are under a lot of pressure because they have to handle all of these problems at once. Right. So globally, there are many health financing models, right? So we are still talking about healthcare financing, right? And then once we do so, we will move on to see, we'll talk about, but then later on, we'll talk about what are our options, okay? Policy tools to be efficient. So major healthcare financiers, the models would be national health services, right? The state provides you for free of charge healthcare system, like ours, in Sri Lanka. It's state provided, free of charge for all levels, at all levels. And then there is social health system. Some countries, so our social health insurance is minute. Can you remember that it was the blue color bar, right? It was minute. But in some countries, their main modality of healthcare financing system is social health insurance. Say, for instance, Japan. But it's a good system. If you get it done, it's a good system. Right? So the social health insurance, in the sense, people go to obtain healthcare, and then the insurance schemes, the insurance companies, they reimburse, or they pay for the provider, meaning the provider would be the hospital. Okay, so they pay the provider. Community-based health insurance. So it could be, people just think about situations like Sanasa Samiti. Right? So there are small organizations, non-governmental organizations or private facilities. They get together, they collect their money, so this is, we are moving on to pooling. We will talk about risk pooling in a bit in the next few slides. So until then, remember, so they collect a little bit of money, so that if someone falls ill, these people get from that gathered money, right? They contribute, they pay their bill. So that is community health insurance. Voluntary health insurance is what we do when we obtain private insurance. Okay, so we pay out of pocket premiums, right, based on our risk, and then if we go to a health facility, say in Sri Lanka, also we can obtain private healthcare, right? So if you go for a surgery, and then you pay your bill and you submit your documents, and the insurance company would reimburse it for you, or some insurance companies, they go there, they then and there pay it for you, right? So that is voluntary health insurance. And some countries don't have any of these systems. They only have out-of-pocket expenditure. If you are ill, you have to look after yourself, and which is a very bad situation to be in. Okay, so risk pooling, right? So in Sri Lanka also, there is a pool. Pooling is you collect something, so that if you are not well, the pool will look after you. Okay, so pooling is the health system function whereby we collect revenues. Okay, you collect it through many mechanisms. There are many mechanisms into the pool, and then you pay the provider through that pool. Okay, so the provider, in the sense, it could be hospitals, clinics, screening facilities, programs, whatever it is. Okay, so the pool ensures that the risk related to, okay, so the risk of financial risk is minimized. So the So it is if the pool is large and if the pool is nicely functioning, it won't allow people to be thrown into poverty because of ill health, right? So and also it improves efficiency and equity. Right. Let's look at the graph. Okay. So there are three figures. So low risk to high risk. Say among us. So now today we have how many participants? We have around 40 participants. No? So some of us would be ill. Some of us would be at risk. Some of us might have NCD risk factors. But some of us would be quite healthy. So the meaning of a pool is, now we put, so we start collecting equitable amount, same amounts from everyone, we collect it, and then we look after the poor people who are at high risk. Okay, so it cross-subsidize from low risk to high risk. So then the high risk are well looked after. Okay, and then sometimes from rich to poor, right? So you take like social insurance or private insurance, or in any insurance scheme, you take from everyone, and then you are also looking after the poor. Okay, social insurance especially. And then if you are elderly, if we are old, when we grow old above 70s, right? And then somebody, we can't pay because we don't have a regular earning, only the pension or the EPF, whatever it is. So then somebody, if that pool is there, the pool look after you until you die. Okay, so that's the basic idea behind pooling and then looking after. So therefore it favors equity and efficiency, right? So our Sri Lankan healthcare system, our healthcare system is, our pooling is tax-based financing scheme, right? National, it's a free of charge for everyone. So therefore we draw money, we draw it through the taxations. Okay, so we collect it from the tax and the treasury pools it, and then it gives to the Ministry of Health or to the provinces for it to be utilized, right? The problem is, because our allocations are not adequate, our pool is also, apart from the pooling mechanism, we also have this out-of-pocket expenditure, right? So I told you, we are more or less, there are 50%. Okay, so the government gives 50%, the out-of-pocket amount is 50%. At the moment, when you actually dissect this out-of-pocket expenditure, what you see is this out-of-pocket expenditure at the moment is, maybe not at the moment, maybe maybe a year ago, it was where the higher economic strata was the majority who was doing this out-of-pocket expenditure. Well, that's fine. They're okay. They're wealthy people. No, they're wealthy people. So why not we allow them to pay for their health? Because they are not going to run into poverty, because they are paying for their health. Okay, so therefore we would allow the other strata, the lower socioeconomic strata, to utilize the free health system, right? But the problem at the moment, what is happening is not that. Okay, even the higher economic strata people, in an economic crisis, they would also turn into the government sector for many reasons, right? So then they get free of charge health. They don't have to spend on drugs and investigations. You know? So therefore, the health sector in a crisis like this would expect a surge of demand. The problem is, are we ready to face this surge? Right? Okay. So I have very briefly given you the flow of funds through the health system. See, there are funders there. This is taken from the national health accounts from Sri Lanka. There are three main funders: the government, the individual citizen, and the donor. So these are the, in blue color, I have shown to you the funders. Okay, there are donors which come through the government and into the treasury, and the government through its taxes into the treasury, and individual payments through its out-of-pocket expenditure. It's another flow. So, anyways, through these collectors, the donors, external agencies, the NGOs, and government collections, it comes into the treasury. So what does the treasury do? The treasury, through the central ministries, say for instance, Ministry of Health or maybe Indigenous Medicine, no? So it gives to the central ministry, and the central ministry will give to the centrally, the line ministry handled institutions. That is one way of allocations. The other way is through the Finance Commission, it gives to the provinces. Okay, so because our system is a decentralized system, I forgot to mention that our system handles the central institutions and the decentral. We also have decentralized institutions. Okay, okay, right. So and then it's moves through the Finance Commission into the health system. Give me 1 minute, please. Right. So, and then the provincial ministries would have handled the provincial institutions. The Army, Navy, Air Force hospitals and the police hospitals are managed by the Ministries of Defense. That's a separate flow of funds. Institutions managed by the provincial government and local governments are funded through the Finance Commission. Okay, local governments are able to generate their tax revenues. So whatever they get through their tax also, they utilize within the provinces. That is the very basic. I'm just giving you the very basics of funds allocations and funds utilization within the ministry. Within the system. Okay, right. Let's have a look at. Okay, so now we know where the funds are coming from and how it is pooled and how much we get, right? So this is another problem we have. Once we get the funds, see where it is put into most. Most of the bulk of the money goes into tertiary care, and only a little bit for the little institution, primary care and health institutions, right? So because of this bulk goes into the tertiary care, the problem is people also have their mindset is, okay, primary care institutions, they don't have equipment, they don't have human resources, they don't have so their mindset this is, they don't have the drugs and the investigations, so we should not be going there, and we should go into a tertiary healthcare system. Okay, so in Sri Lanka, because it is universally free of charge, universally free of charge access, also we cannot say no, don't come to the tertiary care. Okay, there is no gatekeeper facility. Anybody can access tertiary care whenever he or she wishes. Okay, so therefore, the other problem is our primary care institutions or our smaller institutions are very much underutilized. But we have people working there, we have equipment there, and so therefore we are losing a lot of efficiency there. Right? So here, what the proportion wise, if you take the healthcare functions and the allocations, you can see a lot of it goes into the curative sector. 73% into the curative sector. Okay, out of that curative sector also, if you look at it, it is for the inward patient care, most of it, 47%. Outpatient care, sorry, it is only 26%. But look at the preventive care, and even Ayurveda medicine and even the Western medicine, we have preventive care sector also. No? So we want people to be well. We screen for people, but that gets only about the attention it gets is so small, right? It's around 3%. In other countries, okay, so inpatient, so even if okay, let's say it's okay to spend the bulk on the curative sector, but in other countries, what we see is the reverse, this reverse, inpatient, inward care is lesser than the OPD care. In Sri Lanka, it's not seen that. We can't observe that, right? So why we see that in other countries is their outpatient services like daycare services, day surgeries, right? And for some medical practices like say asthma, they don't take the patient inside. They don't have inward patients. They have observation units. They look after the patients there. They send them home. Okay, so there are a lot of list of diseases that they treat as outpatient services. So again, because of these things, Sri Lanka, we spend a lot on inpatient care, especially inward patient care. Okay, right. So again, remember our key statistics. This is very important. The red portion and the blue portion. Right. Now the red portion is high. Out-of-pocket expenditure is around 53%. In 2015, it was 53, and in 2019, it fell below a little bit below 50% in 2020, and now it is beyond 50% again, right? So what happens if people have to spend on their health, right? What are the scenarios? So if majority of the people have to spend for their health care, what would happen? Okay, some people will not go into healthcare seeking. Okay, so then what happens? Okay, they don't want to go to obtain health, and then their disease just get complicated. Diabetes complicated. Hypertension would get complicated. Or the other thing is they go into, say, chronic kidney disease or cancer even. Okay, so these big diseases, if they go into treatment seeking, what would happen? Their catastrophic expenditures would be rising, meaning people would be thrown into poverty because they can't afford healthcare. And then there is also research which suggests when these catastrophic expenditures are happening, there's another arm to it. There would other things that would happen, such as they would cut down on meals. Okay, so the people will cut down on meals because, say, you have a chronic kidney disease patient at home, and somehow you have to take that person into the hospital, right, for dialysis, etc. So that has they cut down on meals, and the second thing they observe is they stop sending children to school. Okay, so these things are the bad ill effects of out-of-pocket expenditures. Right. So this is why the government has to intervene on health. Right. Number one, we already discussed, because health services, it's a benefit, it's an investment. If people are healthy, we assume people work. It is an assumption in Sri Lanka, right? We assume people work. Actually, people have to work if they're healthy. So therefore, they produce. If you don't produce, there is no GDP, gross domestic production. If you don't work, there will be no dollars. So that is that. Right. We assume that people would work. The other thing is equity. So if you provide it for free of charge, irrespective of which strata, which community, or which part of the country you are living in, they can access any healthcare services they need. Okay, so equity issues. And then market failures. There is that is a separate lecture. Healthcare market can also fail. Okay, healthcare market can also fail due to different reasons. And then, so insurance schemes is one reason. And the government will not want the healthcare market to fail. No? So market failure shouldn't happen, because then the equilibrium would go and the prices would be all over the place, and the demand, the supply, the quantity supplied. So market failure is, in economics, it's dangerous to happen. So the government doesn't want healthcare market to fail. So therefore they want to intervene, right? And then, so because other market failures in direct consumption and provision of health services. So market failure should not happen for equity. And also government think, the governments have to think, if we invest on health, people will be healthier, people will be educated, so they can work and earn. Right. So we talked about efficiency, and I told, okay, we'll talk about efficiency a bit later. So efficiency is in financing, the economic costs resulting from changes in the production and consumption behavior of firms and households as a result of tax and other revenue raising efforts. Efficiency in simpler terms is, it is the value for the money. Okay, it is value for the money. Right? So there are two efficiencies that we see: allocative efficiency, meaning doing the right thing. Technical efficiency is doing things right. Right. So efficiency can be gained through allocative efficiency or technical efficiency. Right. Okay. So now we know, no? So in a nutshell, economics, there are three problems. Okay. Needs are indefinite, okay, unlimited, but resources are limited. Resources are land, labor, capital. Resources are finite all over the world, but needs are unlimited. People want healthcare, people want education, food, clothing, housing, recreation, and the resources are land, labor, capital. These are fundamental economic concepts. It would be good if you can keep your mics muted, so that you don't interrupt the other listeners. Resources are finite. Okay, right. Okay, so the fundamental economic problems. So now we are talking a little bit of economics before we move on to see what are the policy tools we have. Fundamental economic concepts are scarcity. Resources are limited. Money is limited. What else? Water, natural resources are limited, right? So nowhere in the world there are unlimited resources, especially finances. Choices. If we are for the choices we make, okay, so the choices we make has a cost to it. Okay, so that is opportunity cost. Each choice we make has a cost. Today, you being here at this lecture has a cost to it. You could have been having lunch, no? So you chose to be here. Therefore, okay, economically speaking, there is a cost to it. So remember that also for the rest of your life. Every decision that you make in your life has an opportunity cost. Okay, let's look at opportunity cost. So it is the lost benefit. Opportunity cost is the lost benefit. So defined as the value of the best alternative foregone as the result of making a decision. So today you being here has the best, for some of you, the best alternative foregone would be having lunch with your friends. So you can cost it actually. Okay, so that there is a value to it. So that is gone. Okay, so you have to keep in mind whenever we are asking for any amount for us, so there might be doctors, healthcare professionals, anyone. So very important concept to know is, right, if we are forcing a choice, if we are asking somebody to make a decision, right, keep in mind that there is a, if if that if that thing that you are asking for is getting funded, it is coming from somewhere else. There is a cost to it. Okay, because we cannot talk, because of scarcity of resources, we cannot accommodate all of our choices. So therefore, somebody is going to lose somewhere, right? The benefit would have to be obtained from the next best alternative is the opportunity cost. So let's look at it. This is what opportunity cost is. Okay, so in pictures, say I give you $10,000, right? And then I ask you to choose from whatever it is. You can have a fancy car, or you can have a vacation, or if you are a really, really good person, you can also donate, right? So if you're asking me, because I'm not a huge fan of cars, and I'm not a really, really good person, I would want to go on a vacation, right? So now my choice made. So my next best alternative, not all three, my next best alternative would be, okay, because the country is in a bad situation, well, I don't want a car, so maybe I would donate. Right? So, but because I made the choice to go on a vacation, I lose that opportunity to donate. And that value of that donation is gone now. So that is the concept behind opportunity cost. The value of the next best alternative forgone. Okay, right, right. So how many people understand this problem? I'll give you, because time is limited, I'll give you 10 seconds to look at this and interpret. Can anybody interpret this? Right. 10 seconds gone. So again, what I'm telling you is, in the community, we have the old, the young, the ammas and the tatas and the disabled and all of it, right? But we also have scarcity of resources. Remember, one in and one out means because of the resources, we can accommodate only, there are only a few options, right? If something is accommodated, meaning something is kicked out also, right? If you are asking for COVID-19 vaccinations, okay, we say as a nation, we want COVID-19 vaccination, somehow get it for us. We have to keep in mind, we are taking it from somewhere else. It could have been medicine, it could have been from a gynae ward, it could have been from a pediatric ward. So this is very important in decision making to remember that every decision that we make has an opportunity cost to it. Okay, moving on to health technology assessment. I'll very quickly go through all these things. Health technology assessment is also another policy tool that we use. It's a research, it's a tool that we use for decision making. Okay, the term health technology is big, right? But what is a technology? Technology means anything we use to improve health, to promote health or prevent diseases in a patient, okay, in a patient or a community, anything. A technology is anything. It could be a building, it could be a tablet, it could be a computer, it could be a pen, it could be a screening program, it could be vaccination, anything that we use to promote health or prevent, diagnose or treat disease or long-term care. So technology, so anything, drugs, devices, procedures, setting, what comes into our head when we talk about health technology is a computer, a person sitting in front of a computer working. No, technology is anything we use to promote health, prevent and treat disease, and improve rehabilitation and long-term care, which includes the following. Right? So health technology, it's a policy tool. Very briefly, we'll look at the steps. It helps policymakers to efficiently prioritize health interventions and services. And it also improves quality and consistent decision making. So if we adhere to health technology assessment principles, consistent decision making, no favoration for me or for you. There is no, because there is a process. We adhere to that. So consistent decision making, and therefore reduce inappropriate variations, not here and there, not inappropriate variation. And a health technology assessment will be able to signal value. Okay, signal value. Okay, this is the cost effectiveness. This is the opportunity cost. That sort of concepts. In health technology assessment, we consider it is a policy tool. We consider, do we really need it? Can it work in my country? Now say we get a lot of donations from Japan, right? So before getting that technology into our country, somebody in the policy making process should think, okay, can it work in my country? Do we really need it? Okay, quality and safety of the technology, the need, the prevalence, the incidence, all these things. And then the health technology would think through the safety of the technology. Let's take as an example a drug, the safety of the drug, the effectiveness of the drug, the efficacy of the drug, appropriateness, implementation, and then finally cost effectiveness, the economic evaluations. All right. So you have to think, so health technology is evidence-based medicine. I'm sure that all of you know what evidence-based decision making is, evidence-based medicine is. So evidence-based medicine to decision-based evidence making. So health technology assessment is more or less, if you take into consideration, it is also a way of evidence-based decision making. Okay. But this is one tool, as I emphasize, this is just one tool, a policy tool. It is not a cure for all system efficiency, but it's rather a process that we can adhere to in the decision-making process. But it's a very transparent process. Anybody, even you can oppose and ask, okay, tell me why is this happening? How did you come to this conclusion? Right? As HTU, if you adhere to that, it is possible, and particularly important in the case of no decision and saving money. So if you really want to reject something, this is a process to do so, because you have evidence, you say on some ground, not because basic gut instincts. So HTE audience, if you say, who would be the audience? Meaning, who would be benefited through this? Policymakers, medical products, pharmaceutical companies, healthcare professionals, academics, definitely academics, NGOs or donors, all of them can be HTE audiences. So now I have put here the networks, because health technology assessment, when you practice it, you would know that they don't work alone, because it's a document. It's a document like a systematic review, right? They want to know. So again, something done in China, why are we repeating here? Well, there might be instances why we have to repeat it here, but we would want to know, okay, what were the evidences that were considered in China? What did they come up with? What were their thinking pattern? Things like that. India has health and technology agency. Singapore has, Malaysia has, right? Health technology agency is one agency actually, and it is a very independent agency. Okay, they produce reports. Let's look at it. That is also there in the slide. So let me, we have 7 more minutes and I will try to stick to the time. So in the UK, they practice health technology assessment. In Australia, they practice health technology assessment. And it is a very independent, transparent process. And they work on one topic for about 6 weeks. Okay, 6 weeks. Topic prioritization and everything, the process of the health technology assessment, I'm not talking. I'm just emphasizing this as a tool to improve efficiency. Okay. So a components of health technology would be comparative clinical effectiveness. If it's a drug, they would look at the clinical effectiveness, and then they would also look at cost effectiveness, service delivery, organizational aspects, the legal frameworks, the ethical consideration, all of it. If it is taken up, if your topic say that you want to introduce a new treatment modality, and this is given to the health technology agency for assessment, they will go through all of these components and come up with the policy brief. Okay, again, the health technology assessment. This framework is applied in order to inform funding decisions, right? The health technology assessment would look at how good is a technology, the safety, clinical effectiveness, cost effectiveness, and social implications. Right. So I told you that health technology agency, it's an independent agency. So that is in the blue section. Okay, so once a topic is given to that agency, they look at it, they go through the evidence that is available for this technology, and they process it, and there is a methodology to processing it, and then they compile a document on this. Actually, it's a big document, and then which has all the components that we talked about earlier, and then there is also a policy brief. Policy brief is for the policy makers, or maybe the minister, or maybe the decision maker, right? They read through it, and I told you, no, health technology is not the only tool. It's not the cure for everything, but it is one document that is considered during the decision making. So it goes into the decision making process, and then they will contemplate the cost, the effectiveness, whether it is going to work in my country, and also the need, everything else, the decision makers from the stakeholders from relevant to this topic. And then once if it is approved to be funded, it goes into the implementation phase. Okay, so what I'm trying to say here is, in Sri Lanka, we have a similar process. Not that we don't have anything, we just haphazardly do so. We have a process, but there is a room to improve. Okay, right. So just before the last slide, right, this fundamental issues. We know that economically speaking, the land, labor, capital, and finite resources and infinite demands, it's a problem to anywhere in the world. Okay, so in health sector, we have to be cautious of what care should be produced and how can it be produced. How much of that care should be provided, because now it is 3.7, no? We are functioning on 3.7 GDP allocation. So it is high time now that we consider about all of these. Otherwise, we are going to compromise quality of the care. Okay. If we are just doing whatever business as usual and just giving quantity, there is a definite risk of compromising quality. Okay, so we have to go through these risks, and then there are other policy tools, not just health technology assessment, not just opportunity costs. There are other tools that we can consider. And my final take-home message is finances limited, right? It's under strain, especially in the current situation, right? Efficiency, equity, universal health coverage has to be maintained. So therefore, this is high time we think about efficiency gains. We have to think about reforms. Okay, right. That's all from me.